Hello, I'm Dr. Teri Thomsen, and we're going to spend a few minutes talking about deep brain stimulation for Parkinson's disease. I am the director of the DBS clinic at the University of Iowa Hospitals and Clinics. So deep brain stimulation is the delivery of electrical current through the pulse generator via electrodes that are implanted into the brain. And you'll learn more about the actual surgery coming up with Dr. Greenlee's lecture after this. So a bit of history, surgery to treat movement disorders has been used since the 1930s. And essentially those surgeries were creating scars in areas of the brain that help control certain symptoms, especially tremor. So while they were in the process of doing some of those surgeries, they used a probe that delivered stimulation to the target, electrical stimulation. During that process, they discovered that the actual stimulation alone, short of creating the scar, produced similar results in terms of improving symptoms. So that led to the development of the actual deep brain stimulator to provide continuous stimulation to the target area. So deep brain stimulation provides benefits that are similar to medication for Parkinson, in particular levodopa, but with typically less side effects, particularly dyskinesias, which are the involuntary movements, similar to what Michael J. Fox has. The deep brain stimulation, similar to medication, can improve slowness, stiffness, and shaking or tremor. The primary targets for deep brain stimulation surgery in Parkinson's disease are the subthalamic nucleus, or STN for short, and the globus pallidus interna, or GPI for short. Outcomes for both are similar in terms of improvement of symptoms, but if the main purpose would be to allow medication reduction in a patient who's already on high medication dosing or having side effects, then the subthalamic nucleus target might be best. If the main problem is dyskinesias and there's some concern about memory, then the GPI or globus pallidus interna might be a better target. Some studies have shown possible less effect long-term on worsening memory with the GPI surgery versus the STN surgery. This is a video of a patient with Parkinson's disease who has a DBS, and you'll see first his stimulator is off, and then it is turned on with controlled tremor.
This is now taken 1 minute after the last video was taken. Moment. And can you put your arms out in front of you for me, please? Go ahead and see if you can. Go ahead and see if you can make that tremor go away for us. Put your arms out in front again, please.
So you can see pretty dramatic improvement in the tremor with the activation of the deep brain stimulator. So in terms of the deep brain stimulator program, there's a multidisciplinary approach. So there are neurologists who specialize in movement disorders that evaluate patients before surgery. There's a stereotactic neurosurgeon to actually perform the deep brain stimulation surgery. In our hospital, that's Dr. Greenlee, who you'll meet next. Neuropsychologists do memory testing before and after the deep brain stimulation surgery. They're looking just to make sure there's not significant cognitive decline prior to the surgery. The surgery may be less well tolerated, and there may be more worsening of memory following surgery if that patient has memory problems going in. So a psychiatrist can be involved if there's concern for mood disorders or other issues relating to Parkinson's that might be an impediment to the surgery. Those would need to be addressed and treated first. Following surgery or even before surgery if needed, physical therapy, occupational therapy, and speech therapy may be involved to assist. So patient selection, in terms of candidacy for the surgery, We evaluate based on overall health, making sure that the patient has realistic expectations about what to expect from the outcome. We need to make sure that the diagnosis is accurate, that there are no what we call red flags indicating atypical Parkinsonism, meaning not straightforward Parkinson's disease, but something that may closely resemble it, but may not respond to deep brain stimulation in the same way. Typically, we're looking for a documented response to Parkinson's medications with symptom duration 5 years or greater. During the first clinic visit in evaluating for DBS candidacy, we'll do what's called a levodopa challenge, which is testing motor skills both on and off medication, just to make sure that the levodopa is actually improving symptoms, because that will predict how well the surgery then will be able to improve symptoms post-operatively. Age, there's no absolute cutoff. It's more based on overall health. As we touched on earlier, no significant memory problems. Formal memory testing is required before surgery. That way we can provide better information in terms of risk management for the patient when deciding whether to undergo the deep brain stimulation surgery. So indications on why a patient may wish to have surgery would include disabling dyskinesias, and that's, like we talked about, are the involuntary movements that occur as a side effect from Parkinson's medications, wearing off of symptoms between medication doses, intolerance of Parkinson's medications in general due to side effects, medication refractory tremor. Some Parkinson's patients have severe tremor and don't respond adequately to medication. And in those cases, the deep brain stimulator may possibly provide more relief of the tremor. So more recently, patients and clinicians have considered earlier DBS surgery. In other words, not waiting until it's like the last resort option or when medications are maxed out. There have been some studies that have shown benefits of earlier surgery in terms of preserving higher level of function later on down the road. So what to expect after the surgery? About a month after undergoing stage 1 surgery, which is the implantation of the leads, the patient returns to clinic for the initial programming. So that takes about an hour or so, and during which time the DBS is activated. We check each of the electrodes and determine an optimal configuration or circuit for the DBS. After that, typically patients return to clinic about a month later for further DBS adjustment. During the initial programming, the patient will be taught how to use their remote control. With that remote control, they can increase or decrease the voltage when at home. Also, at the first or second programming, the Parkinson's medication may be reduced. It depends on how high settings the patient is tolerating and how much relief of symptoms they're getting when off of medication. We do have them come to the initial programming off medication so that we can get a true indication of what the effects of the stimulation are. Then typically for follow-up, patients return to clinic about every 3 to 6 months. So not unlike returning to your regular neurology clinic visits, except for when you have the deep brain stimulator, that would be checked and possibly adjusted at those visits. If need be, patients can return sooner if they're having difficulties or needing an earlier adjustment.
Dr. Thomsen, when is a person eligible for DBS surgery for Parkinson's disease?
Hi, so there's not an absolute cutoff like we talked about earlier. It's based on progression of illness, perhaps the number and amount of medications that the patient is currently taking or has tried taking, and the patient preferences. So some patients are interested in opting for deep brain stimulation earlier in the course. They maybe have heard about it, read about it, and it's something that they're interested in. Other patients never choose to undergo the procedure, even as the disease progresses, because it's just not something that they're interested in, that type of intervention. So it's personal preference, stage of illness, and how well the patient is doing on their current medication regimen. The main part, similar to other surgeries, can take like a month to bounce back. So it depends also on the age and condition of that patient undergoing the surgery. And some people will need to have additional like rehabilitation after the surgery, like physical therapy, occupational therapy, speech therapy, in part for recovery from the surgery, but also because they may be able to have better motor function. So maybe be able to like improve their actual baseline after the DBS surgery. So being able to be more active and more fully participate in the rehabilitation therapies.
Thank you. So while we are on this topic, so getting an MRI, so especially in the earlier years of deep brain stimulation surgery, doing an MRI was an issue. Could you please comment if patients can still get an MRI of different body parts after DBS surgery?
Yeah, it depends on the actual hardware. So the newer hardware is MRI compatible for the most part. It also does depend on the manufacturer. So your specific DBS equipment would have to be interrogated, and we'd have to check with the registration with the manufacturer, depending on the model number, just to ensure that it's MRI compatible. And some of the older equipment is MRI compatible only for head imaging, but not the rest of the body. But the newer equipment tends to be compatible for entire body MRI imaging. But the manufacturer and our radiology department recommend that the imaging be done here under the supervision of the clinic, where we actually have you come in, consent to the procedure, turn the stimulator off, and set it to 0 for safety reasons, and then turn it back on afterwards.
Thank you. And would like to ask a couple more questions. One is on speech and balance. So what's the effect of DBS on speech and balance, Dr. Thomsen?
So in terms of speech, potentially there could be a slight improvement in terms of overall function, in the sense of if you have less off time, you may have less effect on the speech, but there are also side effects of stimulation on speech as well. So that can lead to an overall loss of volume. So it's kind of a plus minus sort of situation. And it also depends on the individual patient as well. In terms of the balance, in general, we tell patients that we wouldn't expect them to have an improvement in balance per se, like strictly speaking balance. But if they have an overall improvement in motor function and less of the off and freezing time, that does lead to an overall improvement in their gait for many patients, and just the improvement in perhaps the lack of freezing and the overall gait, along with the motor improvement with the DBS, may have some impact on the balance.